Meeting to order. We will go ahead and begin with roll call. Shelley?
Great, thank you, Amber. Dr. Rice, I have you attending via phone. Brian Smith? Present. Chester Key? Christopher Gilbert? Glenn Trainer? Here. You can move up here. Jason Johnson?
Here.
Joseph Waterford? Christopher Gilbert's here. Joseph Waterford is absent. Kyle Henson?
Present.
Matt Shaw?
Present.
Sandy Nygaard?
Present.
Sharon Hollingsworth? Stevie Merrill?
Present.
Troy Hoke? 1, 2, 3, 4, 5, 6, 7, 8, 9. We have quorum. We have 9.
Great. Thank you very much, Shelley. So if you wouldn't mind scrolling up the agenda a little bit. Perfect. All right, we will begin with the chairman's report. So attached in your invitation is the attendance report, attachment 3A. As a reminder, if you miss more than 2 consecutive meetings, the DHS will reach out to you and make sure that you still want to be involved in your committee. We currently don't have any vacancies, and we do have 1 new member. Welcome, Glenn Trainer. Thank you very much. Also attached in your packet is the 2026 meeting schedule. So go ahead and check that out. Shelley's got it up on the screen.
I need to note we changed the first set of meetings from January 15 to January 22. So we'll be communicating that out probably as time goes on.
Okay. Great. Moving on to the Bureau report, I will turn it over to Dr. Bradley.
All right, thank you. Well, Nicole was doing the Bureau report, but she had to step out for a minute, so I will try to do justice to this. First, I want to do a big welcome to Bureau Chief Chris Hale. He is sitting next to me. For those of you who are not here in person, we are really excited to have Chris here within the Bureau. He is coming from within ADHS, but new to the Bureau of EMS and Trauma System. This is week 1, and he has been bombarded with many meeting requests. So we look forward to getting to introduce him to all of you. So those of you who are here in person, you can meet him after this meeting. Otherwise, online, hopefully you will get to see him soon. Within the packet, you will see attached a written Bureau report with a number of updates in there. There are some openings for other positions within the Bureau that are included there as well. We also wanted to thank Donna, who just retired recently after 27 years within the Bureau. So congratulations on her retirement. Under the services section area, I just wanted to again call attention to the naloxone Leave Behind program, and a big thank you to all the agencies that are participating in this. As you can see, we have 68 agencies across the state. We have just over 4,700 EMTs and paramedics trained, and 2,400 kits that have been scanned out in the community. So really appreciate everyone's work and efforts towards this program. A reminder for agencies that if your crews forget to scan it at the time they give the kit out, the QR code is the same in all the kits, so they can scan any other QR code to record the data of where that was distributed. We are also trying to do a quick reminder about certifications. We have seen an uptick in individuals with expired certifications. So really asking everyone to remind their personnel those certification notifications go directly to the individual email address that they recorded with the state. So whatever email that they are signed up with the Bureau, that's where that notification for renewal goes 90, 60, and 30 days before. It does come from a .com email address. So I think some people have said that might go to spam, so they do need to check their spam for that. But just want to make agencies aware because we have seen a slight uptick in that. You will see a link to how to sign up for our GovDelivery platform there. Make sure you select Bureau of EMS Trauma System. You can certainly select more notifications, but just to realize that otherwise you may get all of ADHS notifications regarding other infectious diseases. And then we continue to include how to contact both enforcement and certification. If you have any questions, there's some links to FAQs, the website, and direct telephone numbers as well, just because we do get some periodic questions regarding that. Nicole, do you have anything you'd like to add?
No, thank you for doing it.
All right. Okey dokes. I think that is it, Amber. Thank you.
Great. Thank you, Dr. Bradley. Moving on to our discussion and action items. The first one we have is to approve the draft minutes. So on the screen, Shelley has the draft minutes up. If I could get a motion to approve.
So moved. Jason.
Thank you, Jason. Do I have a second?
Seconded.
Is that
Second,
Sandy?
yes.
Okay. Thank you, Sandy. All right. So with that motion, do we have anyone needing to make any updates or changes to the minutes as shown? All right. Hearing nothing, we will go ahead and take to a vote. All those in favor of approving the draft minutes, say aye.
Aye.
There was a bunch of eyes in the room. Sorry, I was on
Aye.
mute.
Any opposed? And any wishing to abstain, also say aye. I couldn't hear everyone, but I believe that motion passed with everyone in the room. So thank you very much. Moving on to our next discussion item, if I can get a motion to discuss the following STR training that was created for IV.
Brian Smith was first. Do we have a second?
Kyle with a motion.
Thank you, Kyle. All right, we will discuss this training here. We tried to put together all of the different IV fluid maintenance, all those STR topics as a sort of a bundle presentation. So this presentation is actually quite long. It is attached in your agenda. The beginning of the presentation mostly goes through some basic anatomy related to things you might need to know for starting IVs. That is the bulk of the first section. And then it gets into some of the equipment needed. And then the first section is more of the basics of starting an IV, what the different components of the sets are, how to prepare the bag. Selection of different IV catheters. Talking about larger bore IVs for critical patients. Different factors to consider, and then kind of gets into the step-by-step of starting an IV. So really just sort of the basics of the different steps of starting an IV. Attaching our fluid. And then we talk about a few of the complications and discuss some of the ways to prevent and manage them. So IV complications, including infections, clotting of the line, hematomas, infiltration, signs of infiltration and how to manage it. Phlebitis, I think, is the last one we talk about, maybe. Oh, and then extravasation as well. Circulatory overload signs and symptoms, just kind of continuing the side effects, and then what to do if your infusion stops. So some troubleshooting steps are included. How to change a solution if you have to swap from one bag to another. IV removal. What should be documented related to IV placement. And then an example, a narrative example. We only listed the 2 non-medicated IV fluids because those are the 2 that are included as an STR. A little bit of information about the two. And so this is the section on the maintenance of non-medicated IVs. So this is the second of the STRs. So different considerations related to kids and elderly. And then venous blood sampling is the next of the STRs that's included in this sort of bundle package. This has to do with how to do a straight stick to collect blood specifically without an IV placement. So again, going through kind of the same steps. Some of it's a little bit redundant, but what you need specifically to do just a blood draw. Some troubleshooting steps again, and then drawing from an existing line. So what to do if you have an existing line in and you're doing blood collection from an existing line. So it goes through the steps of how to waste what you need to waste and collect the
Sorry,
blood.
Amber,
Yeah.
can we go back, when we say it says drawing line from existing IV? Should that be
Oh.
drawing blood?
Yep,
I just was, for those 3 slides, I just saw it should probably read drawing blood.
yep, you're right.
All right.
I don't always look at the title. You get the words. Thank you for catching that. Perfect. And then how to do your blood sampling if you're doing it when you start the IV. And then obviously would be paired with a sort of skills session or whatever the medical director had decided, but that is the end of the presentation. So it's quite long. Obviously it's meant to be include all of the different things and could be broken apart into sections if you were teaching some, but not all of these.
And then Amber, just to clarify, I know we had discussed the ultrasound guided IV. That one's going to be a separate one, correct?
Yeah, we're going to do that one separate.
Okay. Thank you. Thank you for all the work. I know this was quite a bit to put together, but it does cover, as kind of a reminder to everyone, we have to have training curriculum available for all the SDRs. The current version is just kind of a several 100-page outline document. So this is going to replace that. And we are getting very close to now having these training curriculum for all of our SDRs. So a big thank you to this committee that's worked on these. Brian, I see you. Yeah, Brian has a question in the room, Amber.
Oh, great, Brian.
On patient reassessment for IV, I've had people have these kind of set up the new slide.
I'm just
You'll have
moving.
to repeat.
I'm moving the audio closer to Brian. Sorry.
Sorry.
Yeah.
So, patient reassessment in the IV section,
Mm-hmm.
should it have perhaps, IV site, reassess IV site also? That's,
We could include that. I don't remember where that was.
Do you have a slide number?
there were, I couldn't,
Oh, 53, Matt.
I couldn't find any slide numbers on the way it was coming across my Adobe. I
Mhm.
tried, but it was all Adobe, so.
So
IV site,
Yeah.
and what's that?
Shelley's asking what you're suggesting.
IV site,
Where would you like it on there? What would,
reassess, it can go right after it, and you just go down the third bullet or.
Thank you, Brian.
Okay, and then the next one is on the extravasation slide.
Mhm.
There's a lot of these slides to go through, but I wish I could show numbers on it, but. Okay, so it says there are few medications, in the second bullet, there are few medications used in the pre-hospital setting that can cause tissue damage. And I'm wondering if it would be better worded to say there are a few medications used in the pre-hospital setting that can cause tissue damage. I think that draws to the fact that there are some.
Yeah, there are some, very few. But yeah.
Okay, now, I've got 4 on the blood draw section. One is the vein selection, and I saw that one of my things has been corrected, but
I think that's down lower, Shelley.
it'll
Blood
be
draws.
lower in the blood down towards the blood draw.
Am I warmer?
Yes.
Now,
Go down one?
it says vein selection,
Oh,
comma and can't. And it looks like the 1 to 3 minutes got fixed from when this came out, so can't, the third bullet down. That 1 to 3 minutes was messed up too, but it looks like that got fixed. Okay, oh shoot, I had one more IV thing here too. Equipment, and we'll go back to that. Equipment and proper blood draw.
further down.
Hold on a second, let me see if I got one in there maybe. Hold on, maybe. No, I think it's further down. Equipment and unless that was revised after this came out.
Which slide
It's
is it
back
on?
up. Well, I have equipment and preparation and blood draw, but
Yeah, we had 3 meetings, so it could have been corrected in the last meeting.
since this came out,
Where
This
did you
was-
print this from? I don't think it's
it was on the it was on the agenda website stuff.
I have done some, like, formatting, updates.
Well,
Did you print out the post-work version?
well, I don't know, it was whatever was with the agenda on the website. Um,
What's the correction?
well, there was something about collecting the food and the order of the draw, but it didn't say what the order of the draw was.
There's the order of the draws right there. Is that what you're
Oh, there
referring
it is.
to?
Okay. The order of the draw is crucial, but it doesn't say, somewhere it seems like it should say what the order of the draw should be, what color tubes you start out with, so you don't get cross contamination.
I think we put in there that it wasn't the color, it was if you're collecting the blood culture or not, if you're drawing the blood culture.
Well, the
prior.
blood culture is first, but they're still in order. Red top. There are I found 2 different deals on the web, on the internet about it, but like purple should be last.
I think
Red,
we chatted, Brian, I think we chatted a little about this, but decided that because every institution has their own set of
Mhm.
like specifics, we decided not to put that in here because most of these are going to be in the hospital. So every hospital kind of has their own. And so we decided, I think we discussed it and decided not to, because every hospital is going to have a different set of tubes and may have a different order.
Okay, that's fine then.
Yeah.
Yeah, because I think part of this is recognizing we have to create the SDR because it's on our SDR list, but realistically, anyone who's doing this is working in a hospital that's going to go through training at their facility for this. So it's kind of a little bit combo. Kyle?
Question for the data selection site. Is there something in there that states, speed distal to either current or future ID sites?
So the question is,
Have something in there about that, but I don't remember now. I'd have to go back and search it.
there are two people that recall that being in there, so I feel pretty confident that it's buried in there somewhere.
I think it's in there somewhere related to like if you have to start a second IV, it might be in, if your IV fails, it might be towards the bottom.
Not functioning if they have like a fistula.
I can't remember. You could probably control F for the word below, maybe. I don't know. I can't remember if we used that word specifically, but.
Below.
Close, Shelley, so close. Were there any?
So we do have start with the vein that's most distal to the sites. We can go through.
No.
Sorry, can you
Not
say
that
that?
one.
On slide 18, we do have start with the vein at the most distal site so you can move upward as needed for additional insertion sites. But nothing, I don't see specific.
That's all the data selection says most accessible or most. It's like most accessible vein.
Because for blood draws, it'll be different than for infusion sites. Because for a blood draw, you could draw from any vein, but for an infusion, you'd want to go distal.
Does say under factors to consider is one of them, and then there's one higher up I'm looking for.
Mm-mm.
I think if you
to
go down,
selecting- Sorry, I
Go
was
ahead.
gonna say, if you go to selecting the site, it says start with the vein at the most distal site. And if you go a few slides down, it says about not going about a subclavian, not doing anything below a major one.
I mean, I think the factors to consider might be a good place to just slide in a bullet there, just as a reminder, because it's something to consider. So I think that's probably a good place to just add that in.
It's just a question I have is, are we going to limit the number of sticks attempts that they make? Or is that just kind of,
that would all be institution specific or medical director specific.
Okay.
There's nothing in statute that speaks to that at all.
okay, thank you.
Yeah, thanks, Sandy.
Were you asking a question about blood?
Yeah, so blood draw specifically.
Blood
So
draw
if we have an
specifically,
IV
not start with an
insert,
ID.
Then we don't want to do a blood draw above the IV side because we're going to get, if we're infusing for the majority.
Gotcha.
So
We're
instead
going
of
to
add
loosen
that,
that IV.
So maybe,
So that's when it goes for that
on slide 58.
vein selection. Yeah.
So 58, you have to add something then.
Draw blood distal to an infusion site or an infusing IV.
That works.
That works, yeah.
Slide 58 or slide 59?
58 is taking the vein, so that's probably the best place to put it.
yeah, I think it's a good reminder there.
draw blood distal to current or future IV sites.
I would say distal to current
Yes.
infusion site, because I think that's really what you're talking about, is making sure you're not drawing proximal to that and then diluting the sample. Ryan, you want to go back to your list?
Yeah, so since this is in the blood draw, there's one I think called incomplete collection. Okay. Okay, so on the first bullet, try another tube, use a smaller tube with less vacuum. So when I went and looked up the amount of vacuum in tubes, you could have a 10, you could have a 6, which is smaller, but it has the same amount of vacuum in it. The 2 ml tubes had 75 instead of 100 that all the 6s and 10s showed. So it would seem like to delineate that the smaller tube with less vacuum is a 2 ml syringe or a 2 ml vial. Because otherwise, if somebody's got a 10, they think with the 6 they're getting less vacuum. They're not going to, just because it's smaller.
Or we
So-
just delete that altogether and just say, try another tube.
I would probably recommend just saying try another tube, period, just to keep it simpler.
Yeah, agreed.
Again, this is going to be institutions going to have set policies and processes for this, so probably less specific is better.
Agreed.
And my last one is on IV drip set. So unfortunately, we have to go back up.
Anybody throw me a slide?
Which one are you
What's the
looking-
title?
IV drip set.
How to select the IV drip set?
There it is. That's the one right there. Should this have one for blood tubing? Because that's just kind of a special deal too, blood tubing.
Well, they can't use blood, so
No, but, well, since you're implying this is supposed to be for hospitals more, maybe it doesn't make a difference because they could certainly have blood tubing in the field to hook up. But maybe it doesn't matter if you're going.
This
it's
is-
only gonna be-
No, the blood draw is specific to the hospital. The IV, there's certainly parts of the state where EMTs are doing IVs. So that's, I think, the blood draw portion, I don't
Oh,
think there's
yeah,
any
okay.
EMT in the state that's doing blood draw in the field. But I think that's specific to
So
hospital.
blood tubing, and it's usually 10 to 15 drop per ml.
There's 20 out there, but let's put a sign up.
What's that?
There's a 20.
There's
Put a
a-
sign up here, but EMT's
Not good.
not do a sign up yet.
Oh, yeah.
Maybe 10 and 15 is exactly what you're saying, Brian.
Pardon?
Change that to a 10, a 15, and a 60. Those are your options technically. Or you can buy a
Or we
select
could
version.
do that. And should that more be GTTs per ml rather than S's after those?
sure.
How does it need to appear on the slide?
Add a
What's
10 and a
that?
15. Add a 10 and a 15, and then it should say GTT for
Slash ml.
Do a 20.
No, I think you can delete 20.
Delete the 20. Thank you. Did I capture it correctly?
And then I had one more note, and I don't know if it would fit in here or not. Should it have the formula for calculating drip rates? Because I couldn't find it anywhere there being a formula for calculating drip rates.
I don't think that anyone is accurately calculating the rates in the field. It's either running wide open, TKO, or it's automatic. So I'm not sure if there's any benefit to actually add it.
Well, there are very, very few that have pumps because they can't.
Right, but I doubt that they're gonna be able to count trips in the back of an ambulance.
Yeah. Well, they're only allowed to monitor non-medicated fluids, so it's just
Yeah.
saline or,
Saline.
Yeah.
so it doesn't really, they don't need to calculate anything.
They can only do non-medicated fluids. So the point from Dr. Rice is that a rate's really kind of irrelevant at that point.
I'm done. Not right.
Thank you.
Oh, yes.
Another suggestion, if I could. Like, there you go. Yeah.
Slides 4 and 5.
54 and 55.
Oh,
Yeah, there you
54.
go.
Okay.
It seems like the content here is mostly focused on preparation. And there's slides 54, 55, yet the preparation slide is slide 22. I'm wondering if this information, those two slides should be bumped earlier in the slide sets and be placed closer to preparation, which
Yeah.
is slide 22.
Yeah, that's a good idea.
Okay. And then maybe a smaller suggestion is, I think 22, preparation was talk to your patient, but if it's a pre-verbal patient, maybe guardian too,
Mhm.
/ guardian. It's intuitive, I
Mhm.
guess, in the field, but maybe an emphasis to
I like
focus
that.
on, yeah.
Talk to your parent, let them know you're coming at the kid with the needle.
Yeah, that's a smart thing. to do.
Yeah.
So on, I think slide 22. Talk to patient / guardian.
Or caregiver, because even if it's not. a
Yeah,
kid,
guardian
it's
/ caregiver.
Yeah, there's other populations that are nonverbal.
Thank you. Great suggestion.
Please note for the geriatric and peds.
Look, I think Shelley's asking for placement for the geriatric and peds slides.
Right after 22.
Cool.
I think that's it suggestion wise in the room, Amber.
Great, awesome. All right, well, since we have a motion on the table already, if there's no other suggestions, I'll move this to a vote as well. All in favor of accepting the training with these modifications we made today, say aye.
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 Any opposed? And any wishing to abstain? All right, that one passes. Moving on to our next item, which is the children with special health care needs. A big thank you to Dr. Munn and the rest of the group who spent a lot of time on this with the PACES committee to make this really wonderful training. So this training goes through, and we've seen a previous version of this before in this committee. We went through and edited it just to make it a little bit more field friendly. And so if you go through here, there's some case scenarios related to some children with some special health care needs. Talking about chronic and complex conditions, giving some demographic information. Talking about the role of parents and caregivers, specifically with children with special health care needs. Baseline vitals might be different. Communication. Talking about where you'd find a specific medical history for some of these children. Go bag, something that a lot of children might have if they have specialized equipment. Some transport needs related to them. They may not necessarily need to go to the closest facility. There might be some special considerations. And then it gets into the sort of assessment portion of what you're looking for. We tried to focus on some of the more common things that providers might see. Tracheostomies, central lines, feeding tubes, shunts, catheters, talking about children with some neurodiverse children and some neurocognitive problems. And then that's the end of the presentation. So I think the PACES group did a really good job putting this together. I think it's a good length for this type of presentation, and I will open it up to see what anybody else thinks. Shelley, I don't think I took a motion on this one, so I'll also take a motion to discuss and approve.
Can you go to?
Wait, so can we get the motion on the table first, please?
So motion, Jason.
All right,
Thanks,
there's a second from Chris in the room.
Thank you. Sorry, I moved on too quickly.
Second slide, maybe a second or third slide. Okay, right there. So we had a discussion about the use of the acronym for children and youth with special health care needs, and I noticed it got changed in all the other slides where it was noted except for this one. So I don't know if there's a reason that it's left in here, but it is in several other places in the slide set, and it did get changed back to not using the acronym. So that's my only comment.
Yeah, I wasn't in some of those meetings, so but yeah.
I think there was a concern that the acronym was considered maybe not like offensive to some, but then if you go to all like the national resources at the end, they all nationally use that acronym. So I know I had really questioned that in the work group of why we wouldn't use that acronym if that's the national one and all of our references. So if you scroll down to the end, and I see Jordana, maybe you can speak to that. But if you go down to, I think, the very last slide, and it gives you resources, all the resources use that acronym nationally. So it seemed a little bit.
My only thing was that all the other places in the slide said it got changed since we did our last meeting.
And that was, I think, because someone thought that they had recalled that that was maybe an acronym that was not well received in the community. But I don't know, Jordana, if you can.
It's used nationally. The
Yeah.
EIC and HRSA and all them, they use that, and all the other EMSCs across the states. So SHIN is absolutely acceptable, and including we have a SHIN department within the Bureau of Women and Children, and that's what it's called, is SHIN. With that.
Okay, thank you. Yeah. And so I think my thought is to, since we've changed in all the other places, at this point, just leave it, but still at the introductory, leave that definition acronym there, if the
I mean,
group's
there
good with
should
that.
really be like on one of them saying what SHIN stands for, just so people understand what it is.
I
and
think
then
it's-
SHIN throughout the rest of it.
Yeah, I think it does at the top.
Yeah, slide 2 showed it.
Yeah, I think that's all. I think that was.
Yeah, so it does define it right there.
Great. Okay, anything else? Anything in the room, Gail?
No, sorry, no other edits in the room.
And then anyone online, one less chance. All right, hearing nothing, we'll go ahead and move to a vote. All in favor of approving the children with special healthcare needs training, say aye.
Aye.
So,
Aye.
I,
Any opposed? All right, any wishing to abstain? Wonderful, that one passes as well. I think the next item on our agenda has to do with another work group. We have a couple more left. This one isn't for an STR skill, but one we talked about before to go along with some of the TTTG stuff related to child maltreatment. Some folks especially in the southern region, wishing for some training for this. So this came as a request from some folks in the southern region as well. So the next item here is to discuss and approve forming a work group for training materials for child maltreatment. I assume this would also be a sort of education committee PACES effort to
Correct.
jointly develop the training. So do I have a motion to discuss?
so moved. Sandy?
Thank you, Sandy.
Second in the room. Who was the second? Was that Brian? Brian Smith for second.
Wonderful. So I don't know if there's any specific discussion related to this work group. I'm happy to participate and take along anyone else that's willing to. I think if there's no opposition or further discussion, I'm happy to take this to a vote as well.
I think no opposition expressed in the room.
Wonderful. So we'll go ahead and take this one to a vote. All in favor of forming a work group for child maltreatment, say aye.
Aye.
Aye. Aye.
Any opposed? Any wishing to abstain? Wonderful. Go ahead and email Shelley if you are interested in that, or if anyone in the room wants to throw up their hand now.
Actually, Amber, if we can maybe take any volunteers now, I think after the meeting, we rarely get any emails directly. So if anyone knows that they would like to participate now and would like to put up their hand either on the room or online, that would be great. I see Dr. Woolridge. Thank you.
I would like to participate, Sandy.
Thank you, Sandy. I see Chris Gilbert as well. Thank you. For the maltreatment, yes, and Jordana as well. And I see John Holmes. Thank you, John. Are you volunteering? Or I have a question, just confirming.
Well, don't raise your hand or you're going to get yourself in a committee.
Totally invited.
All right, we're taking that as you're volunteering yourself.
Okay.
Excellent.
Cool.
Any other volunteers? Wait, we got a couple more questions. Michelle, are you volunteering as well?
Yes.
Thank you.
Right, I wrote down Dale, Sandy, Georgiana, Michelle Prentice, and John Holmes. Yeah, Chris Gilbert. Did I miss anybody?
And Amber, you got Amber down.
Mhm.
Super, thank you.
All right. Thank you all for being willing to help out with those. The next item on our agenda is just a standing item. We have an attached list that has all of the approved training modules and when they were last reviewed and approved. This is where we keep track of everything.
Can we scroll to the bottom maybe and look at the SDR list? I think we've got some on there that are actually done. So we have 824 paramedic med-assisted intubation that's actually complete and published.
Mm-hmm.
And then EMT IM intramuscular, that one is covered under the EMT epi for anaphylaxis. We have that covered there as well.
And the EMTIV stuff is all done.
Yes, all the EMT IV.
Ultrasound.
So then it would just be the ultrasound one, which I think has that work group met yet or not yet?
No, we have not.
Remember I sent you a bunch of stuff for that. Did I send you a bunch of stuff for that?
I think you sent me some stuff. I'd have to go back and look in my email, Matt. But we'll circle back on that and get that one going.
Okay. So I think we had a motion open for that work group, if I recall. So I don't think we need a motion for that one. Is that correct?
It was bulk.
Bulk, okay.
Yeah.
So we've got the work group open still for the ultrasound guided IV.
Does anyone there want to throw their name in for this one? I don't know that we have a list of volunteers yet for that work group either. So if anyone in the room wants to participate.
Matt, I see Matt. He's got his hand up.
Yes.
Glenn, are you volunteering? Glenn Trainer is as well. All right, Kyle as well. Thank you, Kyle.
Perfect.
We get a slide deck for it, so at least it's a starting point.
All right, thank you, Matt.
Yeah, I think we already have a good starting point. So hopefully it'll be a quick one. All right. Anything else, Gail, that needs to be amended on this?
I'm just looking for the group to see. I mean, we have some that are probably coming up on being due for review, but I think in terms of, the brew one is a little bit old. I don't know that there's anything new on brew. I'm looking at Dr. Woolrich. He's shaking his head no. So maybe we can do that down the road. On the STR ones, the ones that we still have pending are the AEMT transport vent, the urinary catheter one, and then the infusion pump.
Okay.
So I don't know if there's any desire to tackle any of those currently.
I just really feel like the infusion pump, this could be so specific to the grant.
I know.
I don't know how to go about doing training like that when it's like each pump is gonna have its own unique features.
Maybe, you know what, why don't we take offline? Because I think the transport event I look is in the same category of an issue. Like you're looking at equipment specific items. I don't know how you create STR in that. And I think that would be an opportunity that we look and see, do we really need to have every single STR quote covered in a curriculum? Because it would be impossible to create a curriculum for any number of different commercial products that may change constantly. So we'll take that offline because I think that would address two of them. That would be the infusion pumps and the transport vent. And then that would really leave urinary catheters, the only other one.
Yeah. Yeah, the only thing I can think of for the vent and the pump one, it would be to create like a templated slide deck that had some of the background basics about transfusion pumps, and then basically made like title slides or something, recommending what should be covered. That's the only thing I can think of. And then each individual, they'd have to plug it in for their specific pump and model. But I don't know how helpful that would be to folks, but
Yeah,
be the only way to do it.
I think we can look at the current STR document. We'll work on that offline, Amber, if that's okay, and then figure out what we need to do for that.
Sounds great. All right, I think we're nearing the end. The last item here is the map of statewide training centers. I will toss this one over to you, Gail. I don't know what
This
this is.
was a request that we had. I don't think we have the map yet done, but
Okay.
this was, Julia's shaking her head no. This was a request that someone had asked at, I think, our last round of meetings in September. And so we do have that on a list of kind of
Oh.
items. Just as we look at workforce development, that's where the conversation came up.
Okay.
We create a map, just like we have of other things like naloxone leave behind, but a map of where our education training programs are. I think that would be really useful because we could really break that down into EMT, AEMT, paramedic, critical care endorsement. So I think that would be a helpful map to have for the state of Arizona. So I think more just an awareness that was requested. We are going to work on that, but it's not done yet.
Okay, wonderful. Thank you for the update. That's the end of our discussion and action items. If you have agenda items that you'd like to be considered for a future meeting, please email those to Shelley. Obviously, this year is going to be a bylaws review and then call to the public. So we'll take a brief moment. I'll pause. And if there's anyone that has a call to the public.
No one in the room?
Great, hearing nothing. The next section is the upcoming events. There are a number of upcoming conferences and symposiums. So take a look at that list. Obviously, the Bureau's website has additional information about special events. Our next meeting will be in March of 2026. And with that, we can adjourn the meeting today. Or do I need a motion to adjourn? I'll take a motion.
Take a vote on the motion. I will listen. If you don't take a vote, I will just ignore it.
Great. Then I will adjourn the meeting.
All right. Thank you, Amber. Bye-bye.
Okay.